right. I think we can get started here. Thanks everyone for joining us tonight. We have Dr. Patton here from Rush University Medical Center. He's going to be giving a talk on the basics of a prosthetics clinics. Dr. Patton attended A.T. Still University of Health Sciences, School of Osteopathic Medicine in Arizona, followed by residency at Rush University Medical Center. Currently serves as the Assistant Residency Program Director, and he's primarily an outpatient general PM&R provider, treating a variety of things such as MSK, brain injury, SCI, spasticity management, prosthetics, and orthotics. Dr. Patton, I'll pass it on to you.
Awesome. Thank you, Dante, and thank you everybody else for being here. Sorry I'm a couple minutes late, but I'm excited to be here. If you have any questions or anything throughout the talk, please feel free to enter it in the chat. And Dante, if I can lean on you a little bit to kind of help maybe organize or remind me, I'm going to wait till the end unless there's something really pressing. Go ahead and interrupt, but I get really distracted, so I minimize everything off to the side. So I'm going to kind of focus on the slides for now and go through this. I don't have a ton, but just enough to kind of get us started and then open it up for questions and comments and stuff after that. So I'll maximize everything and kind of be able to read what you guys have written. So we'll get started. Let's see here. There we go. I'm so used to doing goals and objectives, so I included it here, even though this isn't for CME and it's not in a real official setting or anything. But some things I wanted you guys to be able to get out of this, really recognizing the impact and prevalence of amputations in the United States. We'll cover some epidemiological stats on that, whether those kind of numbers tend to glaze your eyes over, if they are meaningful. We'll cover that. I want to be able to assess the most common types of amputation with you guys. Hopefully you'll be able to understand factors that need to be addressed in an amputee, and then we'll go over a brief overview of a prosthetic device. At the end of the day, the way I kind of thought about this as I was putting it together over the last few weeks was, this is the kind of stuff that I feel like anybody who runs a prosthetic clinic like myself would want any learners to know before they came in, or to at least be exposed to. So this isn't meant to be a comprehensive, totally thorough, resource for you guys in terms of like, by the end of this, you'll be an expert at doing amputee clinic, but more so that you understand everything that we're looking at, kind of a zoomed out macro view of what we're trying to encapsulate in these visits, because there's a lot that we actually end up covering, and that's not even covering like the actual components of the device, which of course are important and come up, but there's a lot of other things that as the physiatrist, the medical member of the team, not like, for example, the prosthetist who's actually building the components, but as the medical provider, you need to be addressing in an amputee and that are important, and especially that the insurance companies are going to be looking for, so that you can get the right things approved for your patient and hopefully maximize their function. So this is kind of the things that I'd love for you to have at least been exposed to before coming to the clinic. Again, not memorized, but just have been exposed to, so that you would recognize it when you saw it. So a little bit of background for me. I'm from St. Louis originally. I graduated in 2011 from Xavier University, and a little bit of a background, my major was actually in athletic training. So MSK, musculoskeletal type medicine was always a focus of mine, and something that really motivated me to pursue osteopathic medicine. We had an osteopath in our training room at Xavier, and he was fantastic and kind of inspired me to go into this, and made me interested in that aspect of medicine. In 2016, like Dante said, I graduated from A.T. Still SOMA, for any of you Rams of Reason out there in the crowd. And then it started my residency in 2016 through 2020 at Rush for PM&R. And currently I'm the assistant professor at the Rush Medical College and the assistant residency program. I have a little picture of Rush up here. There we go.
Yeah.
All right, let's try to get back into this. So covering some of the epidemiological numbers here, about 180,000 people new amputations per year. So that's a significant amount of new amputations. And I guess I misspoke a second ago even. It's not people, this is amputation. So there are people who are getting multiple amputations throughout their lifetime. So you could end up seeing somebody who has bilateral lower extremities, or an upper and a lower. And then there's about 2 million people living with limb loss in the United States at any given time. So that's the prevalence. If you think about that, that's hold on a second. It looks like that stopped sharing for some reason. There we go. That's a major city. You know, that's a little bit over or under the population of Houston, which is the fourth largest city in the United States. So significant amount of people living with amputation or limb loss in the United States. Now, the numbers I think that'll be more meaningful, like I said to you guys a minute ago, is these green numbers here. So you can break it down into basically four major categories when you talk about somebody with an amputation. There's dysvascular causes, and we'll get into what that exactly means and the comorbidities that are associated with that. But basically anything that limits perfusion to tissue or thus wound healing. So you think about things like diabetes, peripheral vascular disease. There's a couple of others that we'll get into, but that's a far majority. Over 80% of people with an amputation, it's from a dysvascular cause. And in that 82%, so break that down, 97% are lower limbs. So that's nearly all of the dysvascular amputations in the United States are lower limb cases, and almost a little over 2/3 of those dysvascular cases are associated with diabetes, like I mentioned, a huge comorbidity. So then you think about the three other main causes of amputation in the United States. Traumatic would be one. And I honestly, before I got to residency, I thought that would have been much higher. You know, you think about people who maybe got in a car accident or maybe are military service members who had something traumatically amputated while they were in combat. And it's actually only 16% of amputations. And then we have the other kind of two minor categories, which include congenital, people who are just born without part of their limb, and then cancer related, which are about 1% each. So cancer related, meaning like they have a sarcoma or maybe a metastatic lesion in a certain part of their limb that they need to have that amputated. So like I mentioned before, there's some significant comorbidities that you need to think about when we're talking about amputations. Diabetes is a huge one. Like I mentioned before, over 2/3 of people in the United States with dysvascular causes are associated with diabetes. Smoking is a huge risk factor. You have a 25 times greater risk of amputation by smoking, which is pretty remarkable. Cardiovascular disease, and that incorporates a lot of different things, but you think about like atherosclerosis, PVD, PAD, things of that nature, anything that's going to limit perfusion to the tissues, that's going to make it difficult for you to heal wounds or just keep blood flowing to tissue, and thus make you at higher risk that that tissue might need to be amputated. Hypertension, and then end-stage renal disease. Now, you'll notice that a lot of these things go together or maybe cause one another, and there's kind of a cyclical nature to this, and that makes sense because a lot of people that have these things have also systemic issues, so they're not going to just affect one area or the other. But end-stage renal disease is a big comorbidity that we see a lot, and something that we got to think about, which we'll get to when we think about swelling in a limb and how that's going to affect maybe their prosthesis, or whether they need to get in and out of the house 3 times a week to make it to the dialysis session. So things to think about when you're evaluating somebody for what type of prosthesis is right for them. So I do want to go through all this slide. This is outlining all of the major types of amputations, and it looks busy and there's a lot of things here, but I at least want you to have heard somebody say them and understand what is being basically cut and what is being amputated, so that you, when you get to clinic and you see this, you're not thrown off guard, or you understand what the terminology is. And there's a couple of them on here that are really popular that you certainly have seen before, or at least heard of, and they have multiple names. And so I feel like it would be nice for you guys to understand that there are, excuse me, for a couple of these multiple names, and you'll hear all of them. So if we start at the highest level, basically, of limb amputation that we're talking about, a 4/4 would be this one up here that they're demonstrating, which includes not only all of the arm, but it includes the whole shoulder girdle. So they're not going to have a scapula or clavicle in this case. Most of the time, these are going to be not from dysvascular causes. That's going to be either traumatic or from metastatic lesions in those areas. And so they really need to like radically eliminate a lot of the tissue and bones and things of that nature. So 4/4 is eliminating everything associated with the upper extremity, including scapula and clavicle. The next one down would be a shoulder disarticulation, where they're just taking the humerus out of the glenoid fossa, but you keep your scapula and your clavicle. Moving down, you can have an above elbow or transhumeral. So both of them are equally accepted. The terms, it's nice. Transhumeral tells you what bone they're going through, so the humerus, which makes sense, but you can also call it an above elbow. Then you can have an elbow disarticulation where they just take, the humerus and they separate it from the ulna and radius. Then you can have a below elbow, which is transradial, which makes sense. Now, why they picked that instead of ulna, I'm not actually sure about that, but you will hear that they always basically go off of the radius on that one and not the ulna. And then, of course, you can have like a wrist disc articulation, and and as you see when we get down to the ankle, there's obviously a lot of carpal bones as there are tarsal bones. So there's multiple levels to that, which bones they're going to leave in there and which ones they're going to take away. But generally, they're going to take all of the carpal bones in that case and just leave the distal, radius, and ulna intact. And then you can have a partial hand where they're either taking off digits or they're taking off all of them, or they're going through the metacarpals. There's any number of those depending on how far down they need to go. When we move down into the lower extremities, the biggest one, which is kind of the equivalent to like a shoulder disarticulation, or excuse me, a forequarter, is the hemipelvectomy. So in this case, they're not only taking the femur and everything distally, but they might even take off parts of like the ischium or the ilium, depending on what part of the bones they need to remove. Again, a lot of times related to metastatic lesions in this case. Moving on down from that would be a straight up just hip disarticulation. They take the femur out of the acetabulum and everything distal and kind of leave everything else in the pelvis intact. Moving down from that, and we're getting in more into the more popular, more common amputations, which you guys are probably more familiar with. An AK, or above knee, also known as transfemoral, because that's the bone you're going through, would be when you're going through the thigh. So that would be an above knee amputation. Then there is a knee disarticulation. Now, there are some other rotation plasties and things that those are a little bit more esoteric. I don't expect you to know about that if you were to come to clinic. But if somebody said I had a knee disarticulation, you would hopefully know that that means that they're taking the femur and the tibia and separating them and amputating anything below the femur. One nice thing about this, and I'm not going to go into the details about all of these, but because you're taking a weight-bearing surface, the distal femur, and you remove everything below it, once that heals, you can actually bear weight through that. So that's an advantage of a knee disarticulation, is that those femoral condyles can still bear weight. They're used to bearing weight on top of the tibia. So once that skin heals underneath it, you can actually bear weight through there. So that can be an advantage of having a disarticulation versus an above or below the knee amputation. I think the most common one that you guys are probably all familiar with is a BK, or below knee, which is transtibial. Again, no love for the fibula. They don't even mention that. We're talking about probably the most weight-bearing bones here. So tibia is the one they go with, but it's below knee, or BK. They have ankle disarticulations, so straight up leaving the distal fibula and tibia intact. A Symes actually leaves some weight-bearing pad, so they take the fat pad from the calcaneus and move it up underneath there, so that again, that distal tibia is used to bearing weight on the calcaneus. So if you put a fat pad under there, you can bear weight on that tip. So that can be an advantage there for that one specifically. And then there's a bunch of different partial foots. So one that they give here is show part. I list out, there's a Liz Frank, there's a transmetatarsal. Again, those don't get into the weeds with it. Just know that they can do varying levels of the foot depending on how far up they need to go for source control of an infection or perfusion of the tissue. So when we're talking about a clinic evaluation, there's a lot of different considerations that you might, think about when you're looking at somebody as a whole. And I have a slide for each of these things. So we're going to go into more detail about each of these bullet points, but I just want to be able to kind of give a broad overview of the things that we're going to be thinking about with each patient that comes to a prosthetic clinic. And a lot of times they're very important on their first visit to prosthetic clinic, but can also be important to evaluate each time that they come back to see if there's any changes in these things and things you might need to intervene on. So first of all, thinking about their overall medical condition, we're going to talk about skin condition. We're going to talk about pain, both somatic and phantom pain, obviously very important in amputees. Well, functional status, which includes their prior function before amputation, what they're currently at now, and what they want to get to, or what their potential might be. Their goals, so the patient and their family's goals with this prosthesis or potential prosthesis, and then anatomical considerations like the shape, any contractures that are present, or unique anatomy. And we'll go over a sample of like some basic parts of a prosthesis so you kind of know what the setup will end up looking like. But we're not going to get into the weeds about individual prescription of devices or all the various types of things that you can do. I wanted to kind of keep this more broad overview of things. So when we talk about overall medical condition, there's a couple of things that you want to think about. Again, as the physician on the team, you really want to be the leader in this area and be able to take this broad view where maybe you're a prosthetist or your PT or OT that's working with you. They're going to have their focus and their expertise, and you need to be able to be on top of this and bring this to the table. So you want to assess whether this person looks fit enough to be able to use a prosthesis. There are people who come in that are not cardiovascularly appropriate, and they weren't ambulating before they had their amputation, let's say, and then they have an amputation, and then their primary care is like, well, you got to go to prosthetic clinic now because you had a below the knee amputation, and they are not really appropriate to be walking anyway because they weren't doing it before. So these are things that you want to take a look at. When you think about potential issues that might come into using a prosthesis effectively, you want to also consider their cognition. When you think about people who maybe a traumatic one, maybe they were in a car wreck and they also have a traumatic brain injury, or maybe they had cognitive issues to begin with and then now they have an amputation. Are they going to have the wherewithal to be able to utilize that prosthesis and take care of it and take care of their skin and do all the proper steps to properly have a prosthesis and use it effectively and safely? And then you also, like I said, what medical conditions do you want to think about when you're talking about the fit of a device or how well it's going to work for somebody? So fluid shifts is a huge one. The comorbidities, ESRD we mentioned earlier, is really common in people with amputations. But liver failure, CHF, a lot of other things can cause fluid shifts and swelling. So when you think about fitting a leg on, or even an arm for that matter, you got to think about how are they going to fit into that device, and what, maybe if it's a before dialysis session, they're going to be too big. So you need to be able to build in room for that. But then when they get their fluid taken off, their leg's going to get small again. And they're going to need to be able to fill that space with something. So what kind of things are we going to do to help them keep utilizing that prosthesis despite potentially shifting in their size? Lymphedema, more and more common, and especially when you talk about somebody who maybe had an amputation for cancer, maybe they have lymphedema issues now, and how that might impact their wearability of the prosthesis. And then you always want to take a look at the other side. We'll mention this again when we get to skin, but you look at the other joint or the same joint, but then the other joint as well. So think about, like, well, if they're below the knee, they still have a knee on that side and they still have a hip on that side. So we got to make sure those are okay, and not, a lot of, maybe osteoarthritis problems or injuries to those areas. But then looking at the other leg too, like if they have terrible arthritis on the other side, are they going to primarily be able to bear weight on their sound leg while we're getting the other one ready? So all kinds of things that you want to make sure that you're not overlooking when you're looking at their overall medical condition. So skin is a huge one. And a lot of times, I found that I'm kind of the only person that ends up screening their skin, because either their primary care either doesn't have time to do it, or it's just not on their checklist and they got like 5 other things they're addressing, and so it's not top of their mind, or they're just not even seeing other providers. Like there's a lot of times where they aren't very good at following up with their primary care, or they're having a hard time getting in. And so you really need to be the person that's raising the alarm if their skin isn't looking well. And if they can't get back in with the surgeon or something, then you need to let somebody know sooner rather than later. So you obviously want to look at the incision. So I have this picture here at the top that is a fresh amputation. So this is somebody who looks like within the last couple of days probably had their amputation, and they've got staples along the incision line, and there's really no shaping having done to the limb yet. So this looks nice and healthy though. The tissue looks perfused. There's no drainage or bleeding or anything like that, and all the staples look intact. So that's really a good sign here. There's no like dusky areas or areas that look like it isn't getting perfusion. You also want to look for other areas of skin breakdown. So, and that includes not just around the incision line, but maybe back here or further up, a little bit more proximal on the limb. This person looks like they have distal weight-bearing issues. So they're maybe getting a little bit, their incision line is healed well, but then it looks like the distal tibia is maybe having a little too much pressure. Either they had fell on it and opened that skin, or maybe they do have a prosthesis and it's just
they're like kind of coming down too much into the prosthesis. So that distal end is weight bearing, which is not a no-go. You don't want to be weight bearing on that end. So, they're getting some skin breakdown there, and that puts them at further risk of higher amputation, and you don't want to go higher and higher. Erythema obviously is a big thing and can have a number of etiologies. Infection, of course, comes to mind pretty quickly, but rubbing or irritation, like I mentioned, if their prosthesis isn't fitting well, but also chronic changes from the prosthetic can cause just chronic erythema in the skin. So something to just be aware of and know, like, does this person just always look a little red and we're going to keep a close eye on it, and I've known them for 2 years and it's fine, or is this new erythema for them? Like I mentioned before, the health of the contralateral limb is really important, and you want to check the skin on that side too, because this person obviously got themselves into a little trouble, whether it was, I'm not insinuating it's their fault, but they had maybe a wound on the other side and it got bigger and it got worse, and then they had to have an amputation. You want to make sure the other side is getting proper care too, so that it doesn't also end up in an amputation. And there are people who maybe, like I had a gentleman recently last week that I saw in clinic who had a relatively new BK on one side, and the other side he had actually fallen while he was in rehab and broke his ankle on the sound side. So now he's non-weight bearing on that side. So we were really limited in what we were able to do for him right now, and we kind of had to wait for him to heal and get ortho clearance to start bearing weight on the good side so that we could get a prosthesis and have him start training, because you really need to be able to support yourself on both legs at that point. And then some other issues that I will bring up here in photos and kind of give you some examples. So these are a little bit more, let's say, unique to amputees. So there's a term called verrucous hyperplasia, and this is a picture of it here. It looks kind of warty. This person's looks black. It doesn't always have to look black. It can look skin colored or maybe other colors. Like I've seen it look purple or greenish or blue, but basically it looks like a bunch of warts on the end of the residual limb. And this is actually a histologic slide of it, so just kind of showing that hyperplastic tissue forming these warts. But basically this can become malignant if it's not caught early. So if you ever see warty stuff starting to form at the bottom, it's always a good idea to let a plastic surgeon or some kind of surgeon know about this sooner rather than later, or dermatology in some areas, so that they can take biopsies and make sure that they're following it. And it can happen spontaneously, but a lot of times it ends up actually happening from too much suction at the end of the prosthesis. So they're not fitting in their prosthesis very well. There becomes a vacuum kind of space between them and the bottom of their socket, and it ends up kind of sucking on the bottom of their residual limb chronically, and then that causes hyperplasia to start. So Wolff's law, tissues react to the stresses that are placed upon it. So then they start forming these warts, kind of hyperplastic in that area, because it's constantly having that suction on it, and then it can kind of turn into a bigger issue if it's not taken care of. This person actually has two issues. They have an open wound here, so that's obviously not good. But then they also have, you can see they also have suction issues here. So this looks like it's been, just really pulled hard with suction, like negative pressure there, and it's actually created a bulbous end to their residual limb. So this person, unfortunately, is double whammy in this case and really needs a lot of adjustment to their socket. And honestly, this person probably needs to stop wearing their prosthesis for a couple of months and have really close wound care follow-up, and start wearing their shrinker, which we'll get into in a little bit, to start reforming the shape of this. But this person clearly was in an ill-fitting prosthesis and didn't have proper wound care leading up to this. So pain is another big issue that can come up with amputees, and something that, again, as the medical provider, you're going to be, on the forefront. You're going to be the point person for. And I wanted to be able to distinguish between these three types of pain. Somatic pain being the type of pain that you get right at the end of the residual limb. So that might be associated with the surgery if it's really recent, within the last, maybe couple of weeks or month or so. You might have incisional line pain. You might have distal tibia pain. Just, basically surgery related pain at the end of the actual residual limb. Phantom sensation and phantom pain are very different. And if you've never been to a prosthetic clinic before and you bring this up and you mention that there's a difference, you will just blow your attendings away. This is like a huge thing that The general public doesn't understand, which, you know, no fault to them. They're not trained in this, but even a lot of medical providers screw up sometimes. And so to be able to distinguish this is really important. And I think after a while, patients really start to get the hang of it because they're the ones experiencing it. But phantom sensation is just that you sense that your limb is still intact. So you feel like your foot is there, or that your toes are itchy or something like that. But it's not necessarily painful or bothersome. You just feel like it's there. So this normally isn't a problem. It can be a problem if you wake up in the middle of the night, you're a little groggy, and you feel like your foot's there, and you go to step out of bed to go to the bathroom or something, and it's not there and you fall. So that can be a problem if it just tricks you into thinking you have your foot. But as long as the patient, you know, is able to kind of get past that, phantom sensation isn't necessarily a bad thing, or that doesn't need to be jumped on to be treated. But phantom pain can be pretty debilitating. So some things that we usually try, obviously starting from conservative to more interventional, would include desensitization techniques. So I have two pictures up here at the top. I'll start with this one. This is just somebody taking a little cloth or a cotton swab and just rubbing it over the skin and the incision and moving it all around that distal limb there to try to get those nerve endings to establish that this is the end of the leg. We are totally confined. We're okay. Like this is just a new sensation, and just try to get those nerve endings to calm down and kind of rewire and do some neuroplasticity so that it starts to understand this is the new normal. So just taking claws, hands. I tell people to use lotion a lot because a lot of times it's good for just the skin in general to be really moisturized, but then to have them kind of massaging that area, and it helps them to like physically feel that that's the end of their limb now too. So it's kind of a double. Not only are they feeling it through their leg, but they're feeling it with their hands. And so it just kind of reinforces that in the brain. Taking advantage of that whole idea of like seeing and then feeling is mirror therapy, which is really popular with amputees. So in this case, you would take your intact limb. Now she appears to be the therapist because I think this is her leg looking at it, and he is the amputee, and he's got his prosthesis on right here. But what you would actually do is, if let's say her leg that is covered in the pants right now is amputated, you would take the mirror just like she's got it and hold up your intact limb and look at it in the mirror and move it all around, and your brain interprets the one in the mirror as the other side because it's a mirror image. And then that can actually just within a minute or two of doing that can actually subside the phantom pain, because your brain starts to get this feedback that, oh, look, I can see my leg, it's intact and it's moving, it's okay. And then it signals that part of the brain and it actually stops. So it's pretty remarkable. And if people get into a regular routine with it, it can actually keep it at bay without having to do anything else. Some other things that you can try are your neuropathic agents like gabapentin or Lyrica, of course. Of course, like I mentioned, a lot of people have ESRD. So when you're talking about renal failure, these medications get a little dicey. So when you can stay away from medicines, always try to do that. And the last thing that you can try here is targeted muscle reinnervation, or TMR. So this is a relatively new procedure. I think it's really gotten popular in like the last 5 years or so. There's one plastic surgeon at Rush that's really on top of this and has been doing a lot of cases of this in the Chicago area. But basically, what they do is they have this nerve that's kind of a free-ended nerve now because it was amputated, so it was cut through. And they take a motor branch of one of the muscles that's not being used anymore. So if we're going to take, let's say, a below knee amputation, you don't need your gastrocnemius anymore because you don't have an ankle to be plantar flexing. So there are still motor branches to the nerve that goes to that muscle though. So what they'll do is cut that motor nerve because you're not using it anyway. So it doesn't matter. You don't need motor control of it. Half the muscle's cut away anyway. And then they actually bury that free nerve into there. So they connect it to the little residual bit of the motor nerve that's left. And then it starts to kind of grow its own little peripheral dendrites into that nerve and bury itself into that muscle. So then it has some feedback. And then it actually stops that sensation and can drastically change the course of somebody who's having really refractory phantom pain. It's really remarkable. This guy, Dr. Kurlander, he will do that for people who have been having chronic phantom limb pain, so had the amputation a while ago. But he's actually starting to do more cases with ortho and the vascular surgeons now, where he's going in during the initial amputation, and after they do everything and cauterize and, you know, make sure all the vessels are good, then he'll go in and do the nerve part, and then they close it all up, and then that person should be set for the future. It's really pretty cool stuff. So the next thing that you want to be able to cover with these people is thinking about their functional status. And this is a huge piece. And this will go into what type of prosthesis and what components will be unlocked, so to speak, or be able to be available for the prosthetist to be able to build out the device for the patient. So I want to just touch on the K levels here. Hopefully a lot of you have heard of these before. If not, if this is the first time, then we'll just go through it really quickly. The K level, K doesn't actually mean anything. It was an arbitrary letter that CMS assigned to it when they were coming up with this. So just know it's called K, but it doesn't stand for anything. But there's basically 0 through 4. So 0 just means that the person doesn't really have the ability to utilize a prosthesis, maybe cognitive issues or health issues, or they wouldn't benefit from having it. So their quality of life wouldn't be improved by having it. Again, maybe somebody who's been utilizing a wheelchair for decades and then they had an amputation, they can continue just using their wheelchair. Getting them a prosthetic leg isn't necessarily going to help them. Or maybe in some cases might be dangerous if they do have cognitive deficits and can't learn how to use it properly, and then they start standing and trying to walk on it, and it just wouldn't be a good situation. K level 1 would be somebody who's going to use it mainly just for transfers and maybe limited household distances. So you think about somebody who's using a wheelchair, but they can do transfers if they had a leg. So you get them a leg so they can get from chair to bed or to other surface. And maybe they can get up and their bathroom's too small to get a wheelchair in, but they can get up and walk like the 5 feet to get on the toilet, use the toilet, get up, walk back to the wheelchair, and then go on their way. So that's a very limited household ambulator. A K level 2 would be somebody who can do unlimited household ambulation, but they're a limited community ambulator. So some of our maybe elderly patients that we treat now, they're not going to go out and do a bunch of off-terrain like multi-level things, or vary their cadence is a big delineator between 2 and 3. So they're not going to like speed up. They're going to walk 1 speed. They're going to just move nice and steady through the community. They can do low level obstacles like a low curb or things like that, but they're not going to be doing a bunch of huge community barriers. A K level 3 is basically like all of us, and now granted I'm speaking out of turn here because I don't know all of you, but the average everyday adult that is able to do whatever they need or want to do in the community, that's a K level 3. So you can run with these, you can exercise, you can play sports, you can walk in the community, you can vary your speed, you can walk up and down stairs, you can do anything you want with a K level 3. And then a K level 4 are like highly specialized components. So we're talking about like high level athletes that need specialized components for the sport that they're doing. When you think about like the Olympic blade runners and people who do competitive rock climbing and need special attachments for their leg and things of that nature. So these are like high level kind of more specific things, as well as children, because they're super active and they're growing all the time and they need special little components and things like that. So kids, and then like specialty components for high level athletes is what a K4 would be. And then I just wanted to mention here that there are some people have asked me this, and we do use this on occasion. How do you determine what's what? Like, is there a subjective or an objective way, of determining what level they are besides just kind of looking at them and seeing like, well, what could you do before? What do we think you can do now? There are 2 tests. One's called the AMP Pro and one's called the AMP No Pro, which is basically just this test, the AMP, with the prosthetic or without the prosthetic. And then based on the score, and usually a therapist or a prosthetist will do this test with them. It just has them do a bunch of different tasks physically, and it takes about 10 minutes to do in the office. Then you can assign them to a level if you really want to like use numbers to assign somebody versus just what you get a sense for them for. So of course, patient goals should always be an important decision-making piece here, and really important in prosthetics, because you really need to look at what functional tasks they were able to do before and they want to continue to be able to do going forward. So we're talking about mobility, and that can include ambulation or with a wheelchair. Like I said, just because you use a wheelchair doesn't mean you can't use a prosthesis as well. And then looking at their ADLs and IADLs and thinking about what they need to be able to do to live their daily life. Some people are going to be trying to get back to work once they're healed up and they have a prosthesis. So what types of things are they going to need to be able to do with that leg? You know, are they working at a grocery store, stocking shelves or something like that? Or are they mostly sitting at a desk job? Those types of things are going to make a difference in what you're going to prescribe. And then you want to think about, and I put in quotes here, extracurriculars. So that includes a lot of different things. You know, some common things that I hear from people is like wanting to go to religious activities like church or their mosque. And what does that entail? Not only how do they get there back and forth, are there stairs that they're going to need to navigate? Is there a lot of kneeling or pronating that they're going to need to be doing? So those are types of things you want to think about. You know, what prosthesis, what level would they be good to be able to do what they want or need to be able to do? Going out with friends, of course, exercise and outdoor activities, playing with grandkids. So you got to be down on the floor or being really mobile. So a lot of different things to consider. And maybe somebody's just like, I don't want to do any of that anymore, or I am not interested in going back to church or something like that. And so, you know, you don't want to just assume what they were doing before is what they want to do going forward. But you do have to be realistic. Somebody said they wanted to be able to go salsa dancing. And I looked at the patient and I was like, did you salsa dance before? And they were like, no. And I was like, let's just pump our brakes then and think about getting you walking around first. And if you take up salsa dancing and you need a new leg, then we'll talk about it at that point. But this isn't going to give you magic powers or anything. So limb shaping is another really important piece. And I talked about it a little bit before, and I demonstrate this with a couple of pictures and hit some high yield things that you'll want to know for when you're in prosthetics clinic. So shaping the limb before you start using the prosthesis is really, really important, especially for BKs. And so, I mean, I'm talking a lot about lower extremity again, because they're the most common, but upper extremity too, so that you can fit in. But lower is really important because you're bearing weight through it. You're not usually bearing weight through your arms with a prosthesis. So it's not quite as important, but still important to shape the limb. So this picture up here, this little diagram shows the three main types of shape that you get with a BK. And that includes bulbous, which it tends to be right after, because you got a lot of swelling right down here, you know, when the incision line is healing. But what you want to eventually get to is a cylindrical shape. And you really want to try to avoid a conical shape here, because that will lend itself to having not only prominent bony areas, which are hard to work around in. You don't want to have those high rub, high tension areas, but also you don't want to be distal weight bearing here. So that this kind of puts it in a position where it's going to be hard to hold that person up and support them around the upper part of the leg here, where here you have more contact points where you can put weight through so that they're not bearing weight on the distal end. This kind of forces you to have some distal touching and weight bearing potentially, and so that can be difficult to work around. This is a picture of a shrinker here, this beige stocking looking thing. This is your best friend after an amputation, and that's for upper limb, that's for above knee amputations, below knees. It's basically impregnated with elastic fibers and has a little bit of a silicone beading on the inside of this rim, so it's nice and grippy. And it actually is really elastic, like are tight down here, and then the compression gradually gets a little bit less as it gets to the top. And you want to pull that all the way on that patient's leg and have it be nice and tight and snug. And you can start wearing that basically as soon as the surgeon will let you. So some of them are cool with it, like just put a little gauze over the staples and throw it on like the second or third day after amputation. And the patient should be encouraged to wear it 23 hours a day. We say 23 because if you're going to take a shower or clean up or whatever, you don't want to get it wet, of course, but you want to wear it at night. You want to wear it during the day as much as you can. So this is a person with an AK that's wearing their shrinker here, so above knee. And so not only do they help shape the limb, but they also provide compression. So it helps get that edema out and that swelling. It can also provide really good sensory feedback. So we talked about before desensitization in that area. So it can really help those nerve endings get some feeling and know like, okay, this is new normal. I get some compression. It feels nice and snug. It makes the patients feel comfortable because everything's kind of held together tightly. So the shrinkers are a really nice piece and really important before they get their prosthesis. Here's some pictures here down on the left side bottom that kind of correlate with the pictures up here. So this is somebody who has a really nice cylindrical shape. This little line here is just what we call invagination of the incision line. This is normal. It's you know, some people, their scar heals more inward, and so they just have a little bit of like an indent or a crease here, and that's normal. It's totally fine. This person has more of a bulbous end, as you can see. You can see it's a little scabby, a little dry here, so maybe there's still kind of recent amputation, so maybe there's still some time to get a shrinker on there and help shape it up a little bit better, but this is a little bulbous, and that makes it hard to fit prostheses on, because if you think about having good total contact, it's hard to get contact up here, but fit that bulbous piece through. So, you know, it's, if you think about it, you're basically the amount of space that you go wide on that, like the caliber of that socket, it has to be as wide as the widest part. And so if that distal part is big and then you get it down in there, and then now the top has all this room around it because they're bulbous, that's why that's not a great shape for the person. And then this guy clearly has a very conical shape here. And so that person's probably going to have difficulty with contacting the distal end here, not having a ton of contact points up here. Contracture is also a really important piece to limb shaping. This person obviously has almost 90-degree flexion contracture of the knee. You really want to focus on telling those people right after their amputation, you got to keep your knee straight, or do stretches every single day. When you're sitting in a wheelchair, think about it. It's going to want to sit down like that. And then if it gets contracted, look at how hard it is to accommodate this in a prosthesis, and how off this angle is going to be, and how difficult ambulation might be. Think about trying to walk with your knee bent at a 55-degree angle and all that weight going through like your tibial tuberosity here. So that's really hard to accommodate, and will make you very unstable when you're wearing a prosthesis. If you can get a nice 5 degrees is okay. If you can get it nice and straight, though, you're gonna fly once you get your prosthesis. So making sure that they don't have contractures, or at least they know what they need to be doing to prevent them, is really important. And now I just want to talk quickly about the anatomy of a prosthesis, because I think this is like the coolest part and what everybody thinks about prosthetic clinic, and it certainly is a big part of this. But you could spend several more hours on going over all the different nuances of all the components and the things that you want to talk about, and all the devices and things of that nature for these prosthetics. So I just want to give you some very basic overview of how they're put together and what some of the pieces are called, so that you're familiar with that. And then once you actually get some experience in clinic, you'll be able to really dive in deep and go over all the cool components and the microprocessors and all that kind of stuff. So all prosthetics will have some sort of socket, and that includes the suspension. So if we're going to stick with lower extremity first, and we'll move over to the other side of the screen and look at upper, the socket is this piece here. So the whole black piece here in this case, and then this kind of dark gray one here. So that's the interface between the actual limb and the prosthesis itself. And part of the socket includes the suspension. So they're going to have a gel liner. Like, I like this picture because it actually kind of separates these two things out. This gel liner is basically like neoprene sleeve that rolls onto the residual limb and then allows that to interface with the socket itself. So you may have a pin suspension. Again, I'm not going to get into the nitty-gritty with this, but you might have a pin suspension where there's something kind of in the bottom here that clicks in. You might have a lanyard suspension where you have a lanyard that hangs off here in a little hole down here, and you pull it through to kind of pull that limb down in the bottom. There's suction suspension, there's vacuums, there's all sorts of different suspensions, but just know that the socket will include some sort of suspension. So some way to hold this person's neoprene sleeve that's covering their leg and hold it into that socket piece. Then there may or may not be a joint after that. So of course this is a BK or below knee. So there's no joint here. This is just in place of their tibia, basically. Their knee joint is intact above it. But in this case, this is the knee joint. It's covered with a blue shroud here. But this would be the knee joint for this person with an above knee amputation. Then you usually have some sort of pylon or shank. So that's, again, to give you space here or replace that bone that's there. And then you'll have some sort of terminal device. So that may be a foot in this case, or it could be a device here that would replace fingers or hands. So if we move over to the upper extremity here, you have the same components here. You have a socket here. This is for somebody who has what looks like a transhumeral or above elbow. So their residual limb would fit into this socket. They would have the elbow joint here, and then they'd have the terminal device here, which would be a hook and pincer in this case. And then they have the harness, which, if you can see, this would go around the other arm, and then this would go around this arm. So it's kind of like a backpack sort of thing. And in this case, the cable would actually be activated by them doing protraction and retraction of their elbow, and that actually pulls that thing and helps move the pieces. Again, I'm not going to go into the nitty-gritty of that. It's really cool stuff, but a whole nother lecture topic. This is for somebody who has a transradial. So they would fit their distal part into the socket. They have, this is the wrist or pylon, and then they have the terminal device here. And then you can have a cover for this stuff. So this is showing that here. You can see the pieces underneath, which were demonstrated here. And some people just go without that. They like the kind of mechanical look of this, or they just don't care what, you know, it looks like, and they don't mind just kind of showing off the components. Other people prefer to cover it with a foam, and then you can color match that to whatever, you know, the person prefers. You can make it wild colors even. I have a guy who has a cover like this that's foam. It looks like a real leg. But his entire foot and leg has Bears logos all over it, and it's like blue. It's really cool, but definitely not a natural look. So again, to cover some of the cool stuff as my last note here, the cutting edge is what I'll call this. You know, there's a lot of really neat technologies that are coming out now, and a lot of surgeons that are experimenting with some really, really cool stuff that I think is going to revolutionize how we look at prosthetics going forward. Again, all assuming that insurances and other things will help provide patients with these devices. This over here on the left side is called osseointegration. There's only a couple of medical centers in the country right now that are doing it. I think UCLA is one on the West Coast. There's one in New York, and forgive me, I can't recall which one it is. It's one of the large academic institutions like New York Pres or maybe Mount Sinai, I can't remember. And then there's and then Rush Ortho is doing this in Chicago. We're the only ones in Chicago doing this. But they actually, so this gentleman had a above knee amputation, and what they've done is taken a pylon here and they've actually fused it with his femur. So it actually, there's a component of it that's intramedullary. So if you think about, if you were to look into that femur right now, you'll have the cortical bone, and then you'll have that medulla area in the middle where like a medullary rod would go if they had a fracture, where there's a component that's going into there up through that hole all the way up as far as it'll go, and then it interfaces right at the bottom of that distal part of the femur, and then goes through the skin, and the skin heals around it like that. And then it's actually totally integrated into this guy's got a microprocessor knee, it appears, and then into this shank and then the foot. So this is basically as close to anatomical feel as you can get, because it's actually integrated into his bone. This guy actually has it for his above elbow. So this is going right up into his humerus. And then he's got this piece coming out of here. So it's fully integrated. These things you never take off. You go to sleep with them. I mean, you can unhook this if you need to, but generally you're wearing this all the time as if you had your leg there or your arm. And another really cool thing that people have probably seen some YouTube videos on, if you're curious about this stuff, is myoelectric prosthetics. And this guy, actually, I picked this photo because not only is his prosthetic really cool and he's got osseointegration, but he also has some myoelectric stuff going on here. These are all electrodes that are touching these muscles here in his upper arm. And when he activates certain muscles, those leads send a signal to his like he has basically a computer on board here, and it will move his fingers and his wrist. So in this case, they'll take a microprocessor controller and then take leads and bury them into nerves. So you'll notice the musculocutaneous nerve, the median nerve, and the radial nerve, they'll actually, when they amputate the arm, instead of cutting through them, they'll dissect them down here and then bring them up and innervate them into the chest, or sometimes into the muscles in the upper arm like this gentleman has. And then when they have to learn, it's a long process, but they can learn to like activate those muscles, even though that muscle's not doing anything, because obviously it's not attached to anything right now in his arm. But when he activates certain areas of his arm, that lead is picking it up and then moving a different part of his prosthesis. So it's really, really cool because he's controlling a robotic arm that's attached to him, basically. So obviously this stuff is incredibly expensive and takes a really long time. And you have to have a super dedicated patient and a really good team of therapists and prosthetists and other technicians to help make that happen. But they've really come up with some incredible devices for people. A lot of times you'll see this at the VA, because the VA usually pays for a lot more expensive stuff than private insurers will. So in summary, when you're looking at considerations in a prosthetic evaluation, remember the overall medical condition. You're a physician at the end of the day, and so that's really your priority. Skin condition and pain are huge. Functional status, both before, now, and after, and what they could potentially get to, what the patient and their family's goals are, and then anatomic considerations, like we talked about, their shapes and contractures and things like that. And I included this picture of a hand because it looks so real and it freaked me out one day. This is in the prosthetics lab. It was just sitting on the table. this guy has this doesn't actually move. It's posable. You can move it into different shapes, but it's not active. But he had just this incredible prosthetist that made this thing look so lifelike, and he was coming in to get some pieces replaced on it, and it just looked like a real hand. It was around Halloween time too, so everybody's a little creepy, but it's a really cool stuff that these guys can do. So let me open this up a little bit more now to some questions, and I'm gonna stop sharing screen so that I can see more people. And anything, I don't see anything in the chat necessarily, but we also had to kind of start over again.
So we did give people the option to submit some questions beforehand. So one question that we had was, if you're seeing the application of, AI, artificial intelligence at all, either in, designing prosthetics or in, in the integration of maybe a smart prosthetic or anything like that.
Not necessarily AI in the sense of like what we're seeing kind of coming into like Chat GPT and like search engines and things of that nature. I mean, there are certainly a lot of like technological advances in computer software design and things like that. So like kind of going back to my last slide, or what the 2 slides ago or whatever, was that there is a lot of work in that area to help make leads better and more responsive. Now there are like a handful of cases in the world, we're talking, like I'm saying like maybe less than 5, of people who have actually had implantations into their brain of leads, and then they've had a receiver box on their prosthetic, and then they can like think about moving their arm that's not there, and then it will actually move their prosthetic arm. Of course, that's not AI, but it is a really crazy technological implication, or implementation, I should say. And there are definitely a lot of really cool engineers and scientists working on that kind of stuff. Okay, so the question from Drake here about the scope of practice on a weekly basis and whether this is a weekly thing. Yes. So I am a general physiatrist, I'll say. So I see a little bit of everything, and that's by choice too. I mean, I certainly have things that I enjoy seeing more than others, but I see stroke follow-ups from acute rehab. I see musculoskeletal issues and joint pain. I see prosthetics and orthotics. I see spasticity management. I really like spinal cord injury, so I have a good cohort of patients in my clinic that are spinal cord injury and all of the things that go along with their special needs. So I see a lot of different stuff, and I really like it. I also round at a subacute facility that's affiliated with Rush. So I'm seeing people at a subacute level, or like skilled nursing facility level, which is unique and kind of cool, and a different pace than maybe acute rehab or clinic. So it's kind of the in between. And then I do cover our inpatient unit from time to time when I cover for my colleagues, or somebody has a vacation or something like that, needs some coverage. And I like stepping in and helping out on the inpatient side to kind of keep my skills fresh. But prosthetic clinic at Rush is a weekly thing. There are people who, depending on your setting, if you have a high enough volume and a lot of like, if your practice or if your health system, whatever, just has a huge demand for it, you could do multiple days a week of prosthetics clinic if you really had the amount of patients to keep yourself busy. We do it every Wednesday afternoon, and I'm starting to build out Friday afternoons too, because basically the guy I showed at the beginning, Mike Elson from Hanger, he comes to our prosthetic clinic as the prosthetist and who we utilize the most. So he's in the visits with us, interfacing with the patient, helping us kind of talk about what components we're going to do, and he starts the process in the room even with them, like taking measurements and all that kind of stuff, which is nice for the patient. And then he kind of brings them over to his clinic to kind of finish up the building and the molding and casting process and things like that. But there are other prosthetics companies, so I'm starting to open up slots on Fridays actually to work with a different prosthetics company that's here in Chicago that was interested in having a physiatrist be able to help get people that have amputations the devices they need, and like surgeons aren't sure what to order and their primary care doctor isn't sure how to order it correctly, so they come to us for that expertise. So I'm seeing more and more of it, and I really like it. I really enjoy it. So that's a good question. The question is, with below knee contractures, can you give Botox to help with that? So yes, you can, if you've caught it early enough that it's not an actual contracture. So remember that there is a really important distinction to make when you're talking about contracture versus maybe spasticity or increased tone. So, people will use the term contracture and not actually mean a true contracture, which is a permanent shortening of the muscle and tendon structure, thus creating an altered angle to the joint. So that's permanent. So when they get to the point where they're contracted, like actual contracture, you're not going to be able to fix that with Botox, because Botox is going to only work on reversible causes, and primarily, you need that muscle to be able to get to that full range of motion. So that's one of the things that, let's say we're talking about like post-stroke spasticity, when you range that person, you want to make sure how much can they actually get here, like do we have any room for improvement. So if they have good range, it just takes a lot of effort, then you give that Botox and now they get through that whole range. Great, that's a great outcome. But if you can only get so far and they have a contracture, you have a limited window that you're going to be able to improve on that. So really, prevention is the name of the game for contractures. And so that's why we do. Now, some of the surgeons are really proactive here at Rush, and they'll actually consult PM&R before the person gets gets the amputation, which we love, because we get to go and counsel patients on how everything's going to look and all the steps after they get their amputation, which puts them at ease, but also helps us lay the groundwork for, you got to keep that knee straight. You have to be doing stretches every day. Another important piece that I didn't mention earlier is doing tummy time, because if you're sitting, your hip is at 90 degrees. You got to get that hip open too. You can't have a hip flexion contracture as well. So if you feel like there's the ability for that person to get farther and they're not actually contracted, then you can do some Botox. It's generally not done very often, though. It's not a routine thing. Because again, once they actually have a contracture, they're pretty much stuck. So you really want to try to minimize that as much as possible. All right, so Tejas, good to see you again. Just saw you a couple of hours ago. Let's see, regarding patients who suffer from chronic phantom pain, time frame on interventions like desensitization, the TMR, how long do they typically take? So I mean, before it even becomes chronic phantom pain, again, why it's so important to have physiatrists around people who are getting amputations. You think about community hospitals or maybe health systems that don't have PM&R, and somebody gets an amputation and then they're never seen by a physiatrist. Sometimes they're missing out on a lot of this education. So immediately after the surgery, I'm telling people to start working on desensitization techniques. Now, obviously, you're a little bit limited in what you can do right off the bat, because they have, maybe an open wound still or incision line, or it might be too painful for them to touch, or we might be worried, like, obviously you don't want to mess up your dressings and get things all contaminated. But once they're healing pretty well and the staples are about to come out and everything's looking good, you really want them to be pretty aggressive about doing that. And a lot of our therapists, especially in acute rehab, are really familiar with it, even during their therapy sessions, like starting to do some of that stuff. So that desensitization techniques, and hopefully the patient's really engaged with that, because that's invaluable time that they're going to be living with it all day, all night, where they can be working on that stuff. But then you have the shrinker. And then I tell people, I won't jump to meds unless it's really excruciating before somebody has a prosthesis, because once you get that prosthesis and you start wearing it and bearing weight through that limb again and utilizing it again, that can do wonders for somebody too. And it can really reprogram those nerves and your brain. And so it can really cut down on your phantom pain by starting to utilize that limb with a prosthesis. So I always try to tell people, like, hold out a little bit longer, just like another month or whatever, we'll get your prosthesis, and then let's see how that phantom pain is doing. But if you do need to take the steps of getting a TMR or something, I mean, that can be effective immediately. So, I mean, I've had people go and get that surgery, and then come out the next day and they're like, wow, it's like night and day. It feels so much better. And it's just like this nerve ending that was just crazy. And they finally got it fixed. And now it's like night and day. And then over time, it will eventually get more and more used to being in that specific muscle and feel even better. So it can be pretty dramatic, but there are certainly stages to it. You want to start earlier, the better. But once you get them up and walking in their prosthesis, or if it's an upper extremity, once they start utilizing those components, it can actually drastically cut down on their pain. So I try to hold off on getting them hooked on the meds and stuff early, because they may get away with not having to use it.
All right, thank you, Dr. Patton. I think we want to respect everyone's time. I know we're going a little late, but we did have some technical difficulty, so I wanted to give you some extra time to answer those questions, which we appreciate. But I think we'll call it here. Thank you again for taking the time.
Absolutely. It was great seeing you guys, and appreciate being here.
Awesome. Thank you. Good night, everyone. Thanks for coming.